So good afternoon, everybody, and welcome to our second staff webinar. And I'd like to welcome back the attendees who were here with us in July, and also a large number of additional new people, attendees, who weren't with us last time around. So if we consider last time, we had 700 people registered and attended the webinar, and we had 7,000 views of the recorded webinar afterwards. This time around, we have 1,000 people who have registered. Many of those have joined us already, and we will be recording this and putting it up on the staff website immediately after this. So keep an eye out for that, and we'll send you the link as well. So I'm going to, as I did the last time, going to introduce you to today's panel. Those of you who were with us in July will recognize them all. So Colm, can I start with you, please?
Colm Henry, Chief Clinical Officer, HSE.
Anne O'Connor, Chief Operations Officer, HSE.
Paul Reid, CEO, HSE.
And we also have the Chair of the HSE Board, who will give introductory remarks in a couple of minutes. So we have a lot to talk about today, a number of key themes, as you can imagine: COVID, winter, and also we'll be touching on the corporate plan. So the format is we're kicking off now for 1 hour. We'll finish at 1:30. As I said, we'll have introductory remarks from the Chair, Kieran Devan, and then we will get into an interview style where I will put questions to the panel and hopefully get good, solid, honest remarks and answers to those. We already have questions from you, and we will get questions during the webinar that I will put to the panel as well. So without further ado, Kieran, can I ask you to give your opening introductory remarks? Thank you very much.
You can, and thank you, Paul. Nice to see everyone. And I suppose what I want to do really is, first of all, to say thank you. And thank you for two things. First of all, we came into this pandemic with a couple of things going for us. The first one was the fastest improving life expectancy in the European Union. And the second one was a population which reported self-reported the best health in the European Union. And of course, that isn't an accident. That is because of tremendous work by colleagues across the HSE, our partners, GPs, policy colleagues as well. So we came into this pandemic from a perhaps unrecognized position of strength by many people, but certainly an awful lot going for us. And that is down to the quality of the work and the people of the HSE, as well as others. The second thank you is for everything that you have been doing through COVID-19. Amazing work, amazing innovation, new services being developed at short notice, and new models being implemented at short notice. And living as I do in London and reading the UK press and the international press, a number of times you see some of the great work in testing and tracing, the work of the GPs, the community assessment centres, the work in hospitals, the work across the community being referenced as good practice and good examples. And it's a testament to the work of colleagues across the HSE. When the board was set up, which is only about a year ago, we talked a lot about having three things we wanted to support the HSE to do. One is make further progress on the performance and the delivery of services, financial performance and delivery, but also delivering the right quantity, hitting the services, hitting the national service plan, and so on. The second one was the quality and safety of those services, and making sure that we provide the best possible care and the safest possible care to the people of Ireland. And the third one was the trust and confidence of the public and our stakeholders in the work that we all do. And I think, again, that innovation and that brilliance, which was much more visible to people through the last few months, has resulted in people recognizing that brilliance and that innovation. So again, a testament to the work of colleagues across the organisation. A couple of things looking forward. We'll be hearing more about the winter plan over the next hours and days and weeks. But a little bit from me on another piece of work which is going on, which is a 3-year corporate plan for the HSE, looking forward and saying, what is it we really want to do? COVID aside, winter aside, and what are those big differences we can make on some, big and important topics? Now, it's not saying that, there are other things we won't also be making progress on, but there are particular things we feel the need to make a breakthrough, either to catch up and improve, or to really take the opportunity to change the model for the better, for the benefit of the people that we serve. So you'll be hearing more about that in the next while. And the other thing for me is to say that as we head into winter and all the usual pressures, but with COVID on top, I recognize it is going to be difficult at times. So thank you for everything you have done, but also thank you for everything that you will be doing going forward. You have my thanks and admiration, and that of the board as well. So as we go into those times, please make sure that you look after each other, that you look after yourselves, and we will face winter and everything that it throws at us from a position of strength, but not without its challenges. So thank you all.
I'm sure there are words that are well appreciated by staff right across the country. So thank you for taking time for coming into this today. So let's turn to our panel today. And a lot of questions from me, but also from the attendees on this, and we'll have questions coming in. So we'll just start with you, Paul. If we just look at the figures for Dublin, approximately today 104 per 100,000. Is that concerning to you?
Yeah, it's quite concerning. Right now, NEFIT are meeting, as we know, and this evening the new COVID oversight group will meet and make recommendations to Cabinet Committee tomorrow, and ultimately to Government Cabinet Committee, or Government Cabinet. It is concerning because what we're seeing, obviously an increase in positive cases. We're seeing an increase in transmission now to age 65 plus. We are seeing an increase in our hospitalizations. Just about 4 weeks ago, we had 23 positive cases in hospital. Now we have 73 this morning. We had 6 people in ICU, we 14. So all of the trends are indicating we need to take the appropriate action. So it is concerning. It's concerning for me also from our own health service perspective. We need to help to protect our patients, protect the public, and protect our staff. So it's a concerning one, and it's a very different place than where we were at the start, where it was much simpler. We had a lockdown. It was black, it was white, it was clear. Now we're opening the economy. We're opening society. We're opening social events. So it's a very different phase that we're in now, and the solutions might need to be very different than they were then.
From a clinical perspective, Colin, is it something that you and your peers, your colleagues would be worried about? Because why I say that is because I've heard clinicians come out and say it's being overstated. So in other words, that it's not as bad as we would that we would give an impression.
Well, nothing would give me greater pleasure than to tell people that the virus has changed, and that we're going to see all these positive rates are related to young people and will not translate into illness, dependency and death. Unfortunately, the evidence shows that the pattern, the behaviour of the virus is exactly the same as it was before. And what we've seen in the past few weeks is that pattern moving from positive cases in younger people to creeping increase of cases in older people to a creeping increase, but definitive increase in hospitalizations. And unfortunately and tragically, number of deaths, 14 in September to date against 4 in August. As I say, Paul, I'd love to say that this second surge, if you like, is going to be different, but there's no evidence it will be any different and unmitigated. We will see, we will certainly see pressures on our hospital system, our intensive care units that we don't want to see.
Are you surprised?
Surprised by
the fact that we're back at 104 per 100,000 in Dublin?
Well,
is it something that you would have expected?
This is a new virus. We are learning all the time, not just in Ireland, but internationally. And every country is struggling with this, as Paul Reid says, with this complex challenge of trying to keep society, of trying to reopen society, of protecting what's of value to us, particularly education, particularly our healthcare services, which were suspended, mindful of the impact of the lockdown on people who are most vulnerable in society. And it is a conundrum that is difficult to reopen society, to preserve education, to preserve healthcare services, while at the same time suppressing the virus, is very much an unknown journey for us in Ireland and internationally. So I'm not surprised that the essential reopening of society has led to increased number of cases. The challenge ahead of us now is considerably more difficult than it was in that first phase.
And from an operations perspective, is it that the plan is not working? Is that why we're back to where we are?
No, well, no, I mean, I think that there's been a lot of talk about, you know, the fact that we would potentially face into another kind of third or second wave of this. And I think from the operations perspective, you know, we have had the last couple of months where things have been relatively stable, trying to get back to a level of service continuity. And I think all of the measures that are going on from a health perspective, we are back doing and back thinking about how we can implement things that we had started. We want to continue those in terms of the COVID response. But I think critically, you know, this is bigger than any plan. I suppose this is down to personal responsibility in terms of the population at large. And I think even from if you look at our own staff, we have a very large workforce, and they're not just staff of the HSE, they're members of families and communities. So really it's about trying to influence as many people as possible without being overly alarmist, but really just about the basics. You know, any of us who have teenagers are just reinforcing basic messages about what we need to do to keep each other safe. And I do think that there's a level of fatigue around that. I think people feel they've heard enough, but the figures are telling us something different now, and we need to really pay attention to that. And certainly from an operations perspective, we are scaling back up. We are looking at the impact of the 73 cases that Paul mentioned, the 14 in ICU, and that's starting to have a very real impact in some of our sites already. So we are working to try and really ensure that we are able to respond both to the people who have COVID in our hospital sites, and not just in hospitals, but people that are attending GPs, community testing sites, etc., but also critically to be able to deliver services that we really have to try and deliver for as long as we can to ensure that we have some level of catch up on the activity that was lost.
So we'll come back to the pressure points on the system in due course, but you touched on something there about messages and messaging, and well, just in terms of, we've had a lot of mixed messages come from different quarters over the last, let's call it 2 weeks. Do you think that's helpful? And second part of my question is, how could we actually avoid that? How could we coordinate better? And I know it's beyond the health services to do that.
Yeah, I think what we're realizing and experiencing now is a very different phase. You know, as we've said before, it's probably easier to drive the whole population into a lockdown and have a very singular and clear message and urging and galvanizing the whole public. Anne mentioned the public are probably getting a bit tired, wish it was all go away, wish it would be different. And we do have, there's no doubt about it, tensions at a political system. So we do need to get very soon to a point of having a very unified coalition set of voices that's been very clear with the public, not frightening, not creating fear, but setting out, we do want to keep the economy open. We do want to keep society open. We know as well as everybody, and all people who are listening today, know the impacts of shutting down the health service. So it is about that, and we'll be doing it today, and we always do it. It is about that singular voice that worked in the first phase, that people hear the health system urging the public to do the right things consistently, and they make a difference. And I honestly believe if we can strengthen the voices, strengthen the singular coalition of voices that people are hearing, it will make a big difference. So it is a more challenging phase because we want to keep our schools open. We want to get our colleges open. We want to keep sport and social and cultural events happening.
That's the easy bit, but how do we do that? You know, in principle, it's easy to say that, but to actually do it when you've got different agendas, competing agendas, as we were seeing over the summer. So how do you actually get that single voice?
Well, there's one single competing force against us, and that's COVID. That's the virus. There's one singular enemy, I always like to call it, against us, and that's COVID. And the best solutions in terms of tackling that are the basic, strong public health measures. And it is about, right now, today, We know many of us are probably meeting too many people too often. We know that we have to reduce the numbers of people. We know that we should. Earlier this week, for a very public event, or a very public experience that happened, I was identified as a close contact. I must say, I found that quite frightening, because you then have to say, God, who have I met yesterday? My wife, who would have a vulnerable condition. You know, what about her? So I think we all have to really get to the point of maybe not just thinking that our contacts might have it, maybe thinking that we might have it, and what we do every day, and how we behave, and who we meet, and when we meet. We should be still meeting people, but we need to take real precautions. You know, our public health teams can tell you very clearly, briefly, when you see an outbreak happening, people talk about meat plants. The vast majority of outbreaks are happening in social and housing and home care settings. So you see not just one person in the house or at the meal getting it, you see 6 people getting the virus. So it is really that important.
Very well publicised over the last number of days about the HSE in the business of shutting down dissenting voices. What would you say to that?
Far from it. From the very beginning, we've been listening to people. Primarily over COVID, we listened to public health expertise, because they're the people who are trained and are expert in the management in the public management of infectious disease and limiting its spread, and that's what their work is. So quite rightly, as a nation, and quite rightly as a health service, we've been led by a public health response. In terms of listening to people, we've listened very carefully to the impact of the lockdown. We co-sponsored our own program, National Clinical Program Pediatrics, published a report on the impact of lockdown on children's health, well-being and education. And that has influenced us to a great deal in how we respond, not just myself as a member of NEFIT, but as a HSE Chief Clinical Officer in realising this challenge ahead of us. It's not just an issue of suppressing COVID, but of facilitating the return of healthcare services so that no further harm is done to people. So we're advising us all the time, primarily on the management of COVID or public health, but on the impact of the measures. We listen to a wide range of voices in hospitals, communities, and that growing awareness of the impact of lockdown measures.
Is it the case you listen to the ones that you like as distinct from ones that you don't like? Is it that situation?
I don't differentiate myself from what I like or don't like, but I can assure you that people find that these messages get to me, certainly, whether or not the messages are easy or difficult, they get to me, and no matter where they come from, I will listen to them once that person has a position where they're representing either a group of patients or they're acting as an advocacy for a service, or they're one of our own clinical leaders within our organisation. Our doors are always open to listening to people and learning.
Okay. So just going on to you touched on staff. So we've seen staff under considerable pressure right across the system since the start of this, and they were literally coming out of a very busy winter period prior to that. Is this sustainable for staff?
Good question. I think that it is very difficult, and I really just want to acknowledge what you said there in terms of the phenomenal work that has been going on for many people since March. I know from talking to a lot of people out around the system that it's really difficult. So just to acknowledge that, and just to say thanks to everybody who's been working that hard. I think the challenge for us now is that there hasn't been a let up. I mean, hopefully, you know, people managed to get some reprieve in the last couple of months, but I know everybody didn't. And I think we absolutely have to try and mind each other. It's becoming, and it has continued to be, it hasn't stopped being busy at all really, but it's, you know, continuing to be very, very busy. And we see that, certainly from my perspective, I see that ratcheting up and up and up every week now. And in a way, you might argue that when we were in a full lockdown, it was nearly easier because we were just doing that. At the minute, we're trying to respond still to all of the COVID requirements, and we have more people presenting with COVID. But equally, we're trying to ensure that we're delivering a level of service continuity across the board. And I think, you know, we are at times asking people to split themselves in two. So from our perspective, we are very clear that we need to protect staff. Both from, I suppose, and kind of a supportive, ensuring that people try and get breaks and all of that, but equally looking and recognising the very significant I guess, emotional and psychological pressure that has been on many people. And we have a framework developed around a psychosocial response framework, looking at staff needs as well as the needs of the general public. And I think it's really important that people familiarise themselves with that as we move on. We're really at the early implementation stages, but we are looking at psychological supports. We're looking as part of, I suppose, our work over the coming months around occupational health supports, in recognition of the fact that we can see that staff are finding it difficult. But I think people, everyone has a limit to their resilience. And I think we are seeing people who have been extraordinarily resilient for many months now starting to feel the pressure, and we need to be very open about that, and we need to support people. So I think that it's very real. It's very real for people who are out working in services. It's very real for people who have been exposed to COVID work who maybe aren't from clinical backgrounds. In some ways, for clinicians, they may be used to dealing with certain situations, but we have moved so many people around in terms of responding to COVID that it can be very challenging. So that's very important to us in terms of the work that we're doing.
What would you say to staff, Paul, the CEO, those that are probably feeling a little overwhelmed, don't see light at the end of the tunnel, moving into another winter period, feeling as if, God, here we go again, another spin on the merry-go-round?
Sure. Well, obviously, the first one, as Anna said it, the chair said it, just a massive thanks. I do it every week in our video to staff of what everybody's done for us so far. First of all, we have your back is the first thing I'll say to everybody, because we've put a very strong case to government, and thankfully have secured quite a significant investment of 600 million euros to support us in our winter plan and stepping back up services. And we're just finalising the details of that, because we know it needs an investment in staff. We know we need to provide cover for people who will be sick in winter. We know we need resilience amongst our own staff. So, for example, at the minute we're recruiting 700 people to swab as part of our testing process. And that is to free up people who've been doing this relentlessly for us for 6 months and getting them back to their own job and their own work. So we know we need to build more resilience in the system. We know we need to make a new investment in the system to take the pressure off parts of the system. And we are making that case very strong to government. And thankfully, I can reassure staff that government have listened to us, and we've probably secured the best investment that has ever been achieved to see us through this period ahead. So, but I would urge everybody, watch out for each other. It's really important, as Anne said, people just mind each other, because it's a relentless time. I would love to give people a lens and say, well, by March, but unfortunately, the uncertainty we're living with, it isn't. And I see it, amongst our own team, and there's many people that staff won't see as visible as Anne and Colm and myself. But senior teams are working very hard and relentlessly as well, and we have to give them a relief too. So watch out for each other.
And just to that point, because it's going to bring me to my next question, and I come back to some of the staff questions in a second. But just very quickly, what do you do? Like you've been on this merry-go-round yourself, as you, Anne and Colm, you have. What do you do to get downtime? What do you do in your downtime to try and unwind?
It's interesting. I mean, we are at this as our staff since the 27th of January. People have this big moment of the lockdown in March, but we're all going at this since 27th of January, preparing relentlessly through summer. And just at a personal level, I think take stock with your family. I mean, it's really important. It's important for me. I love a FaceTime with my grandchild in the States. I miss her hugely. She's 1 in 3 weeks' time. And, I said it before, a 20-minute FaceTime call for me will keep me going for 2 weeks. You just get an energy. So find what's important to you. Find what's important, what you value for yourself and you value for your family, and give them time.
Same question.
What do I do? Well, I have I suppose I'm in the privileged position of having 3 active teenagers at home, so that's distracting. But equally, for me, in a way, I've always tried to keep something that is not work related. So for me, cycling is my current thing, and just trying to keep a balance. I think it's really important that we all have something we do that takes us out of work, and it can be very hard to do that. So sometimes we feel as an individual that we want to try and save the world and do everything, but no one person can do that. And our first responsibility, if we want to care for anybody else, is that we have to care for ourselves. So for me, it's about getting out, getting fresh air, and I have tried to keep that going consistently. Sometimes I've been better at it than others, And apologies to anybody who lives in Meath and sees me huffing and puffing up hills, but there you go. So yeah, so getting out, creating space, and things like gardening, just being outdoors for me is my saving grace, really.
Well, fortunately, I live in what is widely acknowledged to be the greatest city in the world, which is Cork. Although tragically for me, as I'm reminded, I wasn't born there, so I'm still, but my passport is still valid, and I get home there at the end of my work week in Dublin. And it's a county blessed with beaches and good places to cycle.
He's like Charlie High. He's from every county in Ireland.
Okay, so we've lots of questions coming in. I'm just going to weave some of them in, and then we'll come back to my own questions. You've touched on some of them already. You've touched on swabbers. Questions coming in. Mark O'Connor, Emer Smith, I see up in front of me there, and it's about redeployment of staff. An awful lot of the allied health professionals have come in to say they've been redeployed to do different parts of testing, tracing, and other roles as well. So they're asking two things really. One is, when are they back to their substantive roles? And then secondly, will there be backfills to get people on a more permanent basis in those roles that have been filled over the summer? So maybe
Yeah, so maybe just to I suppose address that, because I've received a lot of representations, particularly from allied health professionals. And first off, I mean, I come from that stable in a sense, so I know that it can be very difficult sometimes when you're in health and social care to feel like you're being valued, because you're not necessarily the immediate person. So sometimes the work that health and social care professionals do are in the rehabilitation space, they're in the, working in the area of disabilities, mental health, whatever. So firstly, just to say that the role of health and social care professionals is absolutely respected. So that's just to say that first of all. The second thing is, in terms of the need for the redeployment in the first place, everybody will know that we had to very rapidly scale up a testing response out of our existing workforce. So there were many people across the whole organisation who were redeployed, and that is less than ideal for all sorts of reasons. And as Paul said, we are now actively recruiting to ensure that these people who have been deployed into testing, and all of you who come from all sorts of different roles who have been deployed in, our goal is to get people back to their jobs. And certainly for me, from an operations perspective, it's critical that we do, because on another day we're going to be talking about hospital avoidance, supporting discharge for older people, etc. We need all of youth therapists, community nurses, etc., to be back doing those roles to support that work that you've been trained for and are highly skilled at. So I don't think anybody would wish that it was the way it is. However, we are very, very actively recruiting people. Our goal is to ensure that people are freed up to go back to those critical roles, and that will create a significant amount of capacity back in our system. And I understand that for people who haven't been deployed and who are in effect holding the fort in some teams, that it's equally as difficult. So we are very committed to that, both from the group who've been deployed into testing and people who've been deployed into contact tracing, and there's a lot of work going on to ensure that that can happen. So in terms of a timeline for it, we are now interviewing people for testing roles, and it is a very live process. So that will start rolling over the coming weeks as people are recruited and go through the different processes to come on board.
Just from a clinical perspective, Colm, if we would have seen a much publicised number of cases, audiology would have been one example. Did it make sense from a clinical perspective to shift people into roles and then leaving a gap in the services that they would have otherwise provided?
No, it didn't, based on today's criteria. But at that time, in the first phase, all we knew was what we had seen of the experience of the virus in Bergamo, Milan, Wuhan. And our experience viewed through that prism was of our overwhelmed healthcare systems, of inability to deal with the burden of acute illness and of widespread morbidity and death. And it was quite correct at that time to impose the restrictions that were imposed, to focus completely on COVID for a period of time, to allow us to prepare for what we believed was going to be a tsunami of COVID-related care. Unfortunately, through the efforts of everybody in Irish society, through that famous Mehel spirit that we managed to harness back in March and April, that didn't happen. But with the experience of time since then, we have seen the impact of the lockdown measures, the impact of the pause of what were termed non-essential services, perhaps a misnomer. We've seen the impact of those on children, on older people, and others who avail of those services. So that leaves us with a trickier, more complex task now. We're not alone in this. This is happening right across the world. It's how to keep the lid, how to suppress COVID At the same time, not allow protracted cessation of services, not allow protracted deployment of people away from what I'm sure Anne and I would agree are actually essential services, but ones which were suspended for a period of time to allow us to absorb that first wave of COVID. And it is going to be a considerable challenge.
So having seen the impact, would you have done it differently if we could roll the clock back to, let's say, March?
I don't think we had any alternative back in March, but to act where we did, not just as a hospitals healthcare system, but a society, and in terms of government decisions. And we were not alone in that again internationally. What we knew was what we saw. What we saw where there was unmitigated transmission were overwhelmed healthcare systems, even ones as highly developed as that in the north of Italy with extensive intensive care services, and we had no option but to clear the decks and prepare for absorption of an unknown wave of COVID activity. Fortunately, as I said, because of the efforts of everybody and the critical interventions made, that didn't happen to the degree anticipated.
Can I just a very brief point to follow on what Anne said. I recently visited a swabbing test centre in Castlereagh, County Roscommon, and I met occupational therapists, physiotherapists, speech and language therapists who were there swabbing through today, and they obviously did reflect to me they would like to get back to their the core work and what they do and what they're trained and skilled for. But they equally did reflect to me they felt really part of a really good HSE and very proud to be part of a HSE that responded in the manner which we did. And I think the chairman just touched on his opening remarks, and I would restate it to everybody. The strong feedback we've got from surveys, that we do, public surveys, from other bodies, from government departments, has been the HSE and our staff stepped up to the mark, and they've actually transformed the trust and confidence that the public have had in the HSE in this period. So it is difficult, it is frustrating, but do take great credit, as the chairman said. You have transformed the experience of the public in the HSE. It's fragile as we go into winter, but know that what you've done has worked in terms of trust and confidence.
Very good. Colm, I'll flick this one over to you, and maybe one of the other two might pick it up. Additional public health resources. There's been quite a lot of noise, and justifiably so, around public health resources as we're in the middle of a public health pandemic. So what succor can you give to the public health community that their resources will be increased over the next period?
First, I would like to again publicly acknowledge the huge work and commitment and relentless energy of the public health department right across the country. As has been articulated, not just by me, but by clinicians in intensive care and otherwise, other places, the most fundamental defence against COVID is public health. This is their area of expertise, their area of knowledge. They know what the right thing to do is here, and they're our most robust line of defence. In terms of the resources, yes, they were under-resourced, and hence we were engaged before COVID ever came about in a reform of public health, which was known to people in the public health, called Crowe-Howarth. And what we did during the first phase of the pandemic, we rapidly had to upscale them from a very low base of 250 workers to about 750, largely through redeployment. We have now successfully submitted a pandemic workforce plan, which has been discussed this morning with my office with the directors of public health, where we're negotiating a significant and secured a significant investment for permanent recruitment into public health departments to enable them not just to implement this long-awaited Crowe-Howarth reform, which was demanded by public health people over the years, long before COVID, but also to enable them to recruit surveillance scientists, nurses, members of multidisciplinary teams, and of course, doctors in public health.
So when could they expect to see this investment over that period?
That investment has been secured, committed by the Department of Health. And as we speak, people from my office are working through the detail with directors of public health as how we proceed, working with HR to recruitment and making those departments more resilient and capable to withstand whatever lies ahead of us with COVID.
And can I just take it to you then, a question in from Stephanie Hughes, a mental health professional, and seeing that you were National Director of Mental Health there at one stage. As you were aware, there's a never-ending demand for mental health services. The demand has increased in light of the pandemic, related social isolation, unemployment, uncertainty, societal fear, etc. What actions are being taken to manage that psychological impact?
Yeah, we have a couple of things. I mentioned earlier the psychosocial framework. I think early on when we set up our our operations hub to respond to COVID, we had originally, you know, put psychosocial supports in under another work stream, and we very quickly realised that this actually was potentially going to be one of the biggest work streams for us, and that was because we had to respond to the needs of the general public in relation to mental health, respond to the needs of people who were already using our services and attending services, and critically to respond to the needs of staff. So we have had a group working now for several months looking at how we can respond to the psychosocial needs of everybody. And that group has presented now a whole framework to the operations hub that we have all supported, and they are continuing to work. So we will have leads in each area to drive out this psychosocial response. And I think there are a couple of things. We've touched on the staff resilience and support and all the, I suppose, the huge need that there is for that. But for the general public as well, very early on, we updated the website in terms of the response to people and the supports that were available to the general public. We've worked with a lot of our partners and funded agencies. And really, we are looking at how we can ensure that we have, I suppose, a first line of defence. So it's not all about specialist mental health services. It's about people knowing what they can do themselves. We've had access to online, so Silver Cloud, different types of online responses for everybody. And all of that work has been going on over the last number of months and has been broadcast across the system.
Okay, very good. Last question I'll take from here for now, and the column is back to you. Any guidance on primary care therapists, psychologists, SLT, OTs, etc., when they should start seeing younger children who need to be within 2 meters of the staff member, and what measures need to be put in place? And that's come from Sarah Kilroy. Sorry, Sarah.
I'm not sure, there is no, since we resumed, and the indication was given to resume non-essential services at the beginning of May, we have resumed right across the board without exception. Of course, we're not going back to the way things were done in January. We're now delivering healthcare in a COVID environment, which involves additional infection prevention control measures, involves healthcare staff wearing masks if they can't keep 2 meters distancing. But other than that, we haven't specified, and there are no restrictions to the service we're delivering now. So I'm not sure unless.
It's primary care therapists.
Sarah.
So
Sarah, thank you.
Are there additional measures over and above?
There's no additional measures for Sarah. What I would say to Sarah is that we have more knowledge, thankfully, over the past few months about the behaviour of the virus in young children. And certainly it appears that they're not, certainly in school and educational settings, they're unlikely to be a source of transmission within school settings, but they're certainly no more likely and probably less likely than older children and adults to transmit the virus in the community.
Paul, can I just maybe add to that in terms of just in primary care? I think primary care was one of the areas that got impacted upon hugely in terms of people attending appointments in primary care centres and with the different therapists. What I would say now is that we really, really need to see as many, particularly of the people who have attended primary care services who were deferred or couldn't attend or were afraid to attend. And we are rolling out different solutions in terms of attend anywhere. But that's not the be all and end all. We would encourage people to really think as innovatively as possible to ensure that we can see as many people. So we know that we have built up a significant backlog in our therapies, both from children attending primary care, children attending early intervention services, and really just to reinforce that this is an absolute priority for us to see as many people, because we don't know what's going to happen. So in terms of trying to catch up on some of the work that we couldn't do and prepare, hopefully not, but prepare for any eventuality where we have to wind things down again, but just to encourage.
Just one point quickly, if I could, I know there's been a huge innovation by our staff in terms of virtual consultations. I think June it peaked at 80,000. So there's been enormous flexibility and innovation shown by our staff in maintaining that commitment to delivering healthcare, not just saying, well, I wait to be told what I should do next. They have engaged with infection prevention control measures, they've engaged in reopening healthcare services, and they've demonstrated extraordinary flexibility and commitment to delivering healthcare in new ways.
Which is back to your MEHEL.
Yes,
indeed.
MEHEL indeed.
So Marissa Wise is touching on a question I was going to put to you, Paul. She asks, when will the EY corporate report be finalised and published? I'm assuming that's the central review she's talking about there. So.
Yeah, and I'll probably just respond very briefly in 3 perspectives: what it was we set out to do, where we are now, where we see it going. So what we set out to do was look at what is the role of the centre of the HSE, how does it engage with our services, our acute hospitals, our services, our community organisations, what's the role and clarity of the centre versus the services. We started that process in January earlier this year, and we're making some progress. Obviously, we had to cease it in the context of COVID because the priority was COVID. We re-engaged it in June of this year. And as I re-engaged it, we, and myself and the executive management team who were leading this with EY, we wanted to look back in a different lens. So what is the role? That still stands. But let's look back what worked in COVID. What was the role of the centre in COVID? What was the role of the services? How did we work together? And there's huge learnings in that, because what we did see during that period was, yes, direction and clarity from the centre, I expect, but the work, as Colm has just been said, the innovation being led from the services and people just mobilising. So we need to learn from that, and the centre review now is going to learn from that. It's also a couple of other aspects. We now need to look at it from a few different perspectives. Testing and tracing is a very new function and process that's absolutely key for future pandemic management. Public health, as Colm has said, a very new role and function that has to be strengthened in the HSE. The management of our PPE and logistics. We've gone from a 15 million volume of PPE to 1.1 billion euros of stock. So we have to look at those differently, and we have to look where it's at now at the moment. Is I will be working with the board to give them an update at our next board meeting. Obviously, implementation of something like this is a very difficult phase, so we need to call the implementation timeframe. But I expect it'll probably be into Q1 before we start execution some of the recommendations from it.
So do you want to give any sneak previews to everybody looking in today?
Well, just to say, and I said this from the start, from the day I joined the HSE, anybody who believes that structure is the solution to all our solution to health services, it's not. It's about the services, and it's about how we enable the services. So from my perspective, it's really about enabling the services.
So one of my own questions, and somebody sent in a question, I don't have the person's name, Sláintecare, much trumpeted and heralded Sláintecare. We haven't heard much about it, obviously, over the last number of months. Where is it?
Yeah, well, I'd actually say Sláintecare is probably more active than it ever was, because if you look what happened in COVID, Sláintecare was about relieving the pressure on the acute hospital system, investing in our community services, valuing our GPs and the role that they play in healthcare, putting in place new home care, putting in place new solutions. And somebody mentioned earlier on about our community assessment hubs that were put in. So what we've seen in first phase of COVID was an absolute acceleration of what was the major parts of Sláintecare. And indeed for our winter plan, which we're just finalising at the moment, as I said earlier on, major parts of that investment are actually about the core thesis of Sláintecare. So I'd say we're probably doing it with less PowerPoint, we're probably doing it at more speed, and we're probably doing it with the innovation being led from the services, which I think is good.
Do you expect to see a regional health area coming to a cinema near you soon? Is that what we're looking at?
Well, I've been very public, and I've said this, and on the record of saying it. The priority for me, I'm CEO of the HSE, but it's one stakeholder, it'll ultimately be for government. We need to keep our focus in the next 18 months, 2 years on strengthening the services, and regional organisation structure is part of Sláintecare, will be part of it. But for me, while we're dealing with COVID, we have to keep all our focus on the services.
Just to add to that, Sláintecare isn't just the report or the contents of the report, it's a way of thinking that was informed by what we call integrated care, which involves a much more resilient form of community care and broadening the options, particularly for those who in previous years and still are overly reliant on hospital care. And part of our proposed winter plan leans heavily into those principles of developing further the community networks which were started during the 2020 National Service Plan, but expanding on those, building resilience in the community, building teams in the community, particularly for those with chronic disease and for older people, to reduce their dependency on the acute hospital system that ill serves them, because the portal of entry is through an emergency department, which can only deal with, by definition, emergency and urgent problems, but not the fundamental problems underpinning frailty that goes with age and chronic disease.
I can just say very briefly, Paul, I know Laura McGahey, who is the Director of Sláintecare, would be satisfied because the extra investment we got to help us during COVID and to help us in the winter phase is what we want, Laura in particular would have been crying out for. So I think we're seeing the investment and we're investing in Sláinte care initiatives.
So you mentioned winter, Colm, so let's come to the big W word and what's going to happen. We're going to have an awful winter ahead of us. No rugby and loads of problems. Is that what we're going to see?
Well, sadly, I don't have a crystal ball, but I think if we even think about the last couple of years, you know, winter obviously becomes a very busy time for the health system. And this year we have the added complication of having COVID in our midst. So I think there's no doubt but that winter is going to be very challenging. We know that even pre-COVID we had capacity challenges with our hospitals operating at 90-95% occupancy plus a lot of the time. We already had extensive waiting lists for services. We had probably inadequate amounts of funding going towards home support and other community services. And just picking up on the Sláinte care discussion, you know, the whole focus of our winter plans for the last couple of years has been about trying to keep people away from hospital where they could be cared for somewhere else, and then supporting timely discharge from hospital. I think this year it's that in spades. So really we are looking at having additional capacity available.
I heard you say that last year.
Well, last year I think I can't even remember the money we got last year, but I think it's about 23 or 27 million. So
without sounding facetious, like, yeah, is it possible to keep people away from hospitals realistically with the best plan, the best will in the world?
I think, you know, again, just the Sláinte care approach really, yes, it is, but not overnight, I think is the answer. So when we look at what we're trying to drive through the clinical program work that Colm mentioned in terms of integrated care program around older persons, chronic disease management, that is about having an impact on people's health over a period of time. So it's not the immediate, but we won't see it immediately. However, we do know that we will see an impact this winter, because I think what we've seen throughout the last 6 months, for example, if you take the very rapid scale up of our COVID response teams and the community health organisations, really there to support the nursing homes in I suppose in a far more integrated way. But certainly we know that where we can provide supports to people, and critically to GPs. So we know that GPs, again from work that Colm has led on, we know that GPs want and need better access to diagnostics. They need better access to specialist teams, because there are people who get referred into acute hospitals for opinions and for diagnostics, where really those things could be done without people attending hospitals. Our goal has got to be to keep the capacity in acute hospitals for people who really need to be there, and then to seek to provide other care to people in their own homes. I mean, we spend a huge amount of time, as I keep saying, at the health service talking about beds. Most people have a bed in their own home, and we will always need acute beds and specialist beds for people who have a higher level of need. But we also know that by increasing the service and the capacity in services in the community, that we can provide much more support to people to ensure that they don't need hospitals. So I think from our perspective, we are going to build on learning that we've had from winters from the last 6 months, and the investment that we have will allow us really to try and drive some of those things. I mean, in terms of hospital capacity, you know, we will create additional beds. However, we all know that you can't just magic up hospital beds, and you can't just magic up critical care beds. They take time. So when it comes to building sustainable acute capacity, that has to be done over a period of time. And what we're looking at in terms of capacity is really maximising what's there, what's available to us, ensuring that we have other step-down facilities, because we also know that in winter that, you know, we rely very heavily on transitional care, where we can discharge people to nursing homes. Where we have outbreaks in nursing homes from COVID, we can't do that. So we really have to focus on keeping people at home as much as possible. We also have to ensure that we have a range of solutions there to support more vulnerable communities, be they people who are homeless, who have addiction issues, people who have mental health challenges, etc., etc. So we will be looking at a whole range of work streams, again, to deliver services that can really support people, building on COVID. So in a way, it's an incremental kind of build up of capacity and supporting people, their families, and critically our primary care providers and GPs to be able to do more.
Where's the plan, Paul?
Sorry?
Where's the plan, the winter plan?
Yeah, well, the plan, first of all, we've spent quite a lot of time over the past 10 days and people have worked weekends through all of this, so I want to thank them to put it together. Obviously, the first milestone was to secure the funding from government, which has been secured earlier this week of 600 million euros. We know the outline areas, as Anne has just described, what we're going to do as part of that funding, and we're working through in the coming days with the Minister and the Department in terms of finalising the phasing of all of that throughout next year, because obviously we've phasing that will see us, we expect see us through winter, but we know some of the requirements will not kind of just cease at a winter time. So that's a dialogue we're having over the coming days with the Minister.
When can we expect?
We expect it to be launched early next week.
And same question, do you want to give any sneak previews here today?
Well, I think it's the ones that work, as Anne has just described. We know home help hours and home help supports. We know that community intervention teams work where they are in place. They work where they're not in place, they're needed. Community response teams that we've had in place to put our arms and support around nursing homes. Community assessment hubs will be there. But obviously, a significant part will have to be investment in the acute side in terms of capacity, our beds, acute beds, step-down beds, and ICU beds.
So Irish Times reported 2 days ago 1,000 acute beds. Is that feasible for 2021?
Yeah, and I think we can break them down in terms of it's not just acute beds, it's step-down beds, it's subacute beds, it's rehab beds.
Is it feasible to, as somebody once said, you don't just go down to Bargain Town and buy a bed. So, like, is it feasible?
Yeah, I think in terms of the numbers around beds, we just need to be careful because we have beds today that aren't funded. So within our plan, we are also getting funding for beds that we opened from NTPF funding and other sources that would have had to close, which would make absolutely no sense whatsoever in the current climate. And so we have funding secured for beds that need to stay open. We have capacity that is coming on stream. So we know that a number of sites, and again, within winter, we tend to prioritize key sites. So all areas are not equal. They're not equal because of the capacity that they have available to them. They're not equal because of the impact of COVID, and they're not equal because of the population around them. So I think, we are looking at differentiating again in terms of how we allocate resources. Now, within the acute bed piece, that work has already been done. So over the last 3 months, and as part of our COVID response, we have looked and trawled the whole country to see what bed capacity. So within the winter plan, we're looking at beds that are possible within that time frame. We have a longer term plan that looks at bringing in modular builds and other types of things that take longer. So I think, we have to be ambitious. And as Paul said, they're not all just acute beds. So within the acute beds, we have critical care beds, then we have subacute beds, we have intermediate care beds, and we have rehab beds. So we have different types of beds. And certainly we believe that what we've put in the winter plan is doable, and that is why it's there. Can I just make one I suppose a plea? This is a staff webinar, so in terms of winter, something that is really, really important and more important this year than ever before is our flu vaccine. So we will soon be rolling out the Staph Flu Vaccine, and I would really plead with everybody working in our health system that they would avail of that this year, because apart from anything else, we know that we are already stretched. So in terms of our ability to care for people who are vulnerable, it's a really important part of our approach to winter. So just to say that is coming to a place near you soon, and to urge you all to please take it.
Just before I bring Colm in, and on the flu vaccine, Jacqueline Grogan has asked, when will the flu vaccine be rolled out for staff, also for children in school?
In a couple of weeks.
Yeah, the flu vaccine slightly delayed. The staff and healthcare workers arriving mid to end of September, and we expect to have the same. It was a manufacturing issue, but we expect no change in the timeline from last year. So I expect that to kick in by the end of September. And the other question, Paul, was?
The second question from Bippy Murphy. I don't know if it's Bippy or Billy, but it was probably my eyes. Are there ordinary flu vaccination clinics planned for HSE staff this year?
So in terms of our rollout, we have different approaches. We are looking at peer vaccination as well as flu clinics. And this is, I suppose, a classic example of what Paul referenced there. We know that many services do this very well. So there are campaigns locally. We have a national approach to it, but within sites, there is a whole rollout, and there's already a lot of work that has gone on nationally supporting sites. Part of our winter plan is also bringing in flu leads around the country, and that work has been progressing now for some time. So we'll be rolling it out through flu clinics, peer vaccination, etc.
Sure.
Very briefly, just to support what Anne just said there, it won't be good enough this year that we get through the winter with a 60% vaccination of staff. And there's some huge extremes, what we see between geography, what we see between acute and acutes, or community and community. There are some fantastic exemplars. St. Anne's up in Donegal, long-term care facility, 100% consistently. Our Lady of Lourdes Acute Hospital up in Drogheda, 92%. but we have some huge outliers on the other extreme as well. So we really need to be very clear with staff. This is a winter like never before. There possibly can be some rare exceptions where somebody may not be able to get the vaccine, but that's exactly what we should be dealing with this year. So I'll urge everybody, strongly encourage our service managers. We have to manage this on a risk basis, and we have to take up the vaccine.
So what percentage would you like? Don't say 100.
No, high 90s.
High 90s.
You know, I would be very clear.
Do you think that's achievable?
I think if we get behind in a year when we're dealing with a global pandemic, that's where we have to be heading.
Would you advocate mandatory vaccinations?
Well, we looked at this, just to be clear. We had a look at it. We had a discussion with our executive management team. We had a discussion with the board and the chairman. Legislation, first of all, would take much longer. Some countries, some jurisdictions have gone that route. I believe we can galvanise our teams, our staff, our frontline workers who take bigger risks than this, and all of us need to support them.
Colm, why do you think 40% of staff don't take the flu vaccination when it's available to them?
I don't know. To me, all I can say is I think particularly if you're taking care of vulnerable people, and given the profile of patients that come into our healthcare systems, whether it's primary care or hospitals, there's not a day goes by that people don't deal with vulnerable people. It's unconscionable that you wouldn't get the flu vaccine. Can't say it more frankly than that. It shouldn't be seen as an option, but it should be seen as your own professional obligation, particularly this year.
You wanted to come in on the winter plan. Was there something you wanted to add to the winter plan? Okay,
Yes.
just in relation for the winter, I see Erica Morgan has asked, Paul, maybe one for you, is there sufficient PPE available to people working in community services?
Yes, I visited 2 of our stocks of PPE in Kilcarbery and South Dublin, and in Ballycool and North Dublin, and there are some others across the country, and it's a mighty impressive stock. We've also secured an investment that sees us right through to March next year. Thankfully, we're beginning to see Irish Indigenous industry scaling up and being able to supply us with a lot of our PPE too. But equally internationally and overseas, we've secured PPE right through to April of next year on our current orders.
Okay. Just last question on the winter plan, and then I just want to talk about the corporate plan because you're untouched on it. And in relation to the winter plan, disabilities in the winter plan, it's one that always raises a head of steam around this time of the year. We'll just briefly touch on disabilities in the winter plan.
Yeah, disabilities, I guess just we have, the winter plan is focused on winter specific initiatives. And we have a broader, I suppose we started off this process with a broader pandemic plan that brings us up to the end of next year. That captured the winter initiatives and service continuity initiatives. And within the disability sector, we are hugely challenged on the service continuity aspect. So when we look at the resumption of day services and also just having sufficient capacity around disability, and I would put mental health into that space as well, a lot of that relates to service continuity. So within the winter plan, there isn't actually a huge amount around disability services because it has been agreed that would be discussed as part of the continuity discussion. So we are also heading into an estimates process in 3 weeks' time, and that is where we will be pursuing funding for disability services.
Okay, thanks for that clarity. Paul, can I just touch on the corporate plan? Will you just explain to those who may be looking in and may have never heard of the corporate plan, what it is and why it's important for people who are tuned in today?
Yeah, so our corporate plan is where the board of the HSE with ourselves set out a vision for where we want to bring the HSE in the coming years, set out kind of an inspiring vision of what we want to be about, what we want to prioritise, but also a vision that galvanises and connects staff with what they do, with what our core objectives are. So that's an essence. It can't be completely visionary. This is not 20 years out. So the scale or the scope of our current corporate plan is to look with a 3 years and a 5-year lens. So in terms of what we've been doing, very briefly, earlier this year, we engaged with staff on online consultations. We engaged with staff face-to-face in some workshops earlier this year, and we engaged with some members of the public. It's been more difficult during COVID. And we're at a phase now where the next board meeting at the end of September, the board will be, we will be presenting, which has largely been the work of the board because it's the board's corporate plan, the draft corporate plan for their adoption. and ultimately goes forward. But in essence, it's about setting out the priorities for the HSE, how we inspire staff, how we galvanise staff, how we galvanise the public, as the chair had said at the very start. How do we build a public trust and confidence in what we do? How do we protect the people we serve? How do we protect our services?
Is it something you'd urge people, all 1,000 people who are looking here today and probably another 7,000 people who will look at this subsequently, is it something that you would urge them to read, understand?
Yes, because health, for everything we do, it's all about this year and this month, and that's the nature of it. It's about our service plan. What budget do we get for next year? What have we got for the winter plan? But there is a time where we have to step outside of that and be part of a multi-year solution to what we're trying to do. So then we can build our service plan knowing, well, actually, it's not just for this year, it's part of a 3-year phase in getting us there. And I would urge people to, when they look at it, just test, examine from your perspective, from your role, whether you're a porter, a caterer, a clinical surgeon, whatever your role is in the health service, just see what it means for you and how what you do adds value to all of that, because it does.
So we're at an end, and I have to call it here because we have to give a briefing, our weekly operational briefing, very soon in the city centre. Paul, just some concluding remarks, very briefly.
Yeah, very brief from my perspective. Just firstly, again, thank everybody. This has been a most relentless 6 or 7 months people could have been through. We hugely value this opportunity to engage with staff and get their feedback. We would all like to be out and about and engage with people, and hopefully we can all do that soon. But let's use this as a good mechanism in the meantime. But I would just say to everybody, while we're in a difficult period and while more decisions will be made by government about how we control the virus, we do need to give people, we need to give staff hope, confidence. This time will pass. And I believe as it passes and we get to the other end, we will have a much better health service. We'll have a much better connection with the public. We'll have stronger trust and confidence in what we do, because I know we're on that trajectory. So I just want to give people a bit of hope, a bit of confidence. What you're doing is making a difference.
Again, just to reiterate, thanks, and I guess, you know, to acknowledge that we're asking people to work in very different ways, and that'll continue as we approach winter. But it's also an opportunity for people to be innovative. And as Paul said, you know, as we implement the winter plan, we will be working closely with all of the services to learn really from you about what you've been doing that works. So we look forward to, I suppose, ongoing engagement as part of a formal process, but also as part of our engagements through community and acute services. And just to say thanks to all of you.
Just to add to that, one of the nice things of working in a healthcare worker is you're working in a team, and never have teams felt so close and worked so closely than they have in the past few months. And I'd like to thank people for that and ask them to keep that up. Never has teamwork and innovation been so in need.
Okay.
Before you close, Paul.
Sure.
Just before I close, I just want to say one thing, because I said earlier on, sometimes we're the visible part of the executive management team. Some people don't see too much of maybe yourself and other people visibly, because you know, you're behind the scenes supporting us on communications, and we're heading next to a media briefing, as you just mentioned, and the questions might nearly be as spiky as the ones you were asking, because they're spiky enough. But finally, I just want to say to all of our listeners and viewers today, Paul is taking a career break for the next short period, and I just want to thank you for what you've done for the HSE. I know it's a period of a career break, but it'd be remiss of me not to acknowledge what you've done for the HSE, what you relentlessly have done over the last few months, the sacrifices you've made, as many of other people out here have. So I want to thank you for it and wish you the very best of luck.
Wasn't expecting that. Thank you.
A virtual clap.
A virtual clap.
So, I'll close on that with my red face. And thank you to everybody who's tuned in here today. Thank you for the questions. The questions make this, and we haven't answered all of the questions today. I haven't put all of the questions because there are just too many of them. Suffice to say that we will be responding by way of email to the questions, and in as best as we can answer them. Some of them are unanswerable at this stage, but the vast majority of them we will get an answer to you. Also, as I said at the start, a recording of this will go up on the staff website in pretty short order once we edit this. So if you've seen this and you've enjoyed it, you found it useful, which I hope you have, please tell your colleagues that it's there and that they should watch it, because I think it's important that we're all basically on the same message here, that we all understand what we're trying to achieve, because it's difficult unless we actually can do that. So special thanks to the panel, Paul, Anne and Colm. Once again, it's a very busy schedule they have. Taking this time is very important for them to give you as much information as we can. So we'll close on that, and thank you very much.